So 2 weeks ago, I had my college reunion. I went to Georgetown School of Nursing just up the street from here. And we were all comparing notes about what we were doing. One of my classmates is a hospice nurse, and people said, "Oh, wow, that's awesome." One had become a lawyer, was doing health law work, which was really terrific. One was running a preschool. One of my friends, though, had become a life coach. And she said, "I go around the country and I give speeches about how people can improve their lives." We all said, "Well, that's really cool." I said, "Sometimes I give speeches too." And they said, "Julie, you give speeches? Who do you talk to?" I said, "Well, a couple of weeks I'm going to the Institute of Medicine." And they said, "What do you talk about?" And I said, "The tax exemption of hospitals." And they said, "And people listen?" So if someone would just take a picture, especially of this group over here, so I can send it to my classmates and tell them that some people are interested in the tax requirements of hospitals. But my real message today really is that it's official, that hospitals are in part of the public health system, and they are engaged in population health. And I think I can show you how the Affordable Care Act is moving us in that direction, and the Internal Revenue Service and its rules is pushing us even more. There are many provisions in the Affordable Care Act that are pushing hospitals towards population health. Certainly the coverage expansions are so welcome that we're going to have healthier communities. Medicaid expansions are really getting a lot of attention of hospitals. In some ways you might expect, in some ways you might not expect. We are about in 2014, and hopefully most of our states, to achieve those coverage expansions through Medicaid expansions. And hospitals are starting to say, we need a strategy for Medicaid patients. This is a population that has been underserved for a long time because they were uninsured, and they are often a more expensive population. Hospitals don't want them as inpatients because we lose funds every time a Medicaid patient comes in. So looking at how we can keep this newly insured population healthy has become a priority for a lot of hospitals. We're also finding some hospitals, even within their service line, saying Medicaid population is a special population. Maybe our cardiac service line needs a Medicaid strategy. Our oncology department needs a Medicaid strategy. How do we follow up and keep this population healthy? Certainly all of the prevention strategies that we've talked about today, the Public Health Fund, the prevention coverage that other people have talked about are pushing hospitals in this direction. One of the areas that I found really interesting in the past year is that incentive or the penalties, especially the rehospitalization. Now, you may know that hospitals will be penalized starting next year if they have more than an expected rehospitalization rate. And what that is doing is changing the mindset of so many hospital leaders that patients come to us with a past and a future. We don't just see them when they're in that bed. And so I loved the hospital bed with the X across it. Has certainly become a mantra of many of our organizations as they're looking, how can we keep people out of the hospitals? And the way we can do that is partnering with community organizations and trying to keep people healthy. So I think that that's going to be a big incentive. But the biggest, I think, push that we've gotten are the tax-exempt provisions, and that's what I'm going to talk about. Now, in addition to the community health needs assessment and the planning requirements, hospitals also have new requirements about financial assistance, that we must have policies, they must be transparent, how much we can charge patients, what that process is for billing and collection. That's all part of the Affordable Care Act requirements for tax-exempt hospitals. But let me concentrate on the assessment and the planning. Here you see the basic provisions of the Affordable Care Act for hospitals. We have to do a community health needs assessment at least every 3 years. This is built into the Act. We have to get input from community members, and especially persons with expertise in public health. And I think one of the most important provisions is that we must make that community health needs assessment widely available to the public. Someone at the IRS was suggesting to me, well, how will we know if these assessments are good enough? And I said, I don't know that that's your job. I think it's the job of the local community to say, this is what this hospital thinks its needs are, who it's worked with, how it gathered information. And it's really the job of every local community, whether it's from media to school systems, to look at, is this hospital doing an adequate job? It has to be a public document. Now, the Internal Revenue Service has added to those requirements that are in the Affordable Care Act, first in a notice of intent that it published in 2011, and then most recently in April of this year, they published a notice of proposed rulemaking. And here we have summarized in this booklet, and I have plenty of copies with me if you're interested, all of the details from the Internal Revenue Service proposed rule, but I'll just highlight a few. First of all, it says we really are serious about hospitals getting input. Years ago, when I started in this work, a lot of hospitals were sitting, there was one person sitting at a desk with some statistics working by themselves. That certainly is not possible today, and it certainly we didn't get the good results that we would want. But first of all, hospitals must work with at least one state, local, tribal, or regional public health agency. And we're finding that is happening. We must work with members of medically underserved, low-income, and minority populations or their representatives. So that is a very explicit requirement that hospitals must do. And the third way that they must get input is to publish their last three or a total of 3 community health needs assessments and open it for comment from the public. So the public can say, you missed this whole area that, that we think is a priority. So that's another area. We must have a written community health needs assessment report, and that's really, I think, the crux of the matter. What do we publish for our communities to see? We have to define the community, and the IRS really went, I think, as far as it could to tell hospitals to collaborate with other organizations just in this area of defining the community. They said to hospitals, you don't have to just look at your service area. If you are doing a county-wide assessment with your county, you can look at the whole county. You don't have to limit yourself to the population that you traditionally serve. We have to describe the process that we used. So this is a very transparent process. Instead of the IRS saying you must use certain processes to collect data or analyze data, it says you must tell us how you gather that information and analyze the data. So how did you get the input? Who did you work with? What organizations did you work with? What sort of forums or community meetings did you have? Then we have to develop, first, a list of significant health needs, and a hospital decides what it is, what those, and the groups that it's working with, what those significant needs are. And then we have to prioritize those needs, and we have to describe what was that prioritization process that we used. Then we have to describe the potential resources we're going to use to address what those needs are. Something that the IRS added that I think is very important, and that is that community health needs assessment report must be adopted by the hospital's governing body. And so this has to go to the very highest level. So governing bodies are now responsible for approving that community health needs assessment. The second part of the Affordable Care Act requirements has to do with the implementation strategy. Public health people call it the Community Health Improvement Plan. Hospitals used to call it their Community Benefit Plan, but the Affordable Care Act called it the implementation strategy. So what we have to do here is, first of all, and this is in the law, have it adopted by the governing body. So the plan must be also adopted by the governing body, but that was part of the law. We have to describe how the hospital is addressing those needs, and for those needs it's not going to address, explain why they're not. Then the IRS went into more detail when it came out with its proposed rules. It said that for each significant need, a hospital has to say, this is the action we're going to take. And what I found interesting is it got into really some basic public health principles, which is hospital must say, what is the anticipated impact of those actions? So what do you expect to achieve? Then what is your plan to evaluate? So evaluation has to be built into the plan. And I think that, too, is going to drive us to be working more with public health, because that's often the evaluation of community health improvement is often beyond the scope of many hospitals' expertise. So they're going to need either academic or local public health expertise in doing that. What are the programs and resources we're going to be using, and any planned collaboration? And then again, for any of those significant needs that we're not addressing, hospitals have to say why they're not addressing those needs. There are some themes in the Affordable Care Act and then in the IRS rules that I think bear reinforcing. First of all, they both encourage collaboration. It was envisioned that the assessments not be a silo event, that we work with public health agencies, that we work with others. We've recently done a survey of who else in our communities must do a community health needs assessment. And it goes from Head Start programs, federally qualified health centers to apply for their funds, maternal and child health programs to apply for their funds, have to do some sort of assessment of community need. United Way agencies, although it's not a requirement, they all do some assessment in order to determine dispersal of their funds. I think that the framers of the Affordable Care Act, and certainly in the Internal Revenue Service, was motivated to encourage collaboration. It also encourages hospital public health partnerships. That was built right into the Act itself and in more detail into the IRS rules. And so it's absolutely an expectation of the federal government that locally hospitals and public health agencies will work together. Something that is remarkable, if you're reading the IRS rules, the preamble and the proposed rule together, is the emphasis over and over on with attention to disparities and to vulnerable populations. And so it is very clear that hospitals have to look at the needs of their broad community, but zero in on those disparities, zero in on the most vulnerable populations. And I think the last theme that you see in both the Affordable Care Act and also in the Internal Revenue Service rules is the transparency. Tell us what you did, tell us what you found, tell us who you worked with. So this has to be a very open process, very different from the years ago when people were working by themselves. Well, what is happening from this? Hospitals are collaborating. I think a great example, I was just talking to some folks last week from Billings, Montana, an extremely competitive competitive town, the Billings Clinic and St. Vincent's Hospital. They don't collaborate or partner on anything except community health needs assessment, and then they will on their implementation plans and strategies going forward. Organizations who never had collaborated before are working together. Now, I will say, and I don't know if John agrees with me here, is the one place we're not seeing much collaboration is Boston with all those academic medical centers. But I don't want to offend anyone, but if you're from Harvard, I don't think you collaborate with anybody, you know. So each of the academic medical centers is doing their own. But they're doing some wonderful assessments. But in just about every other community I'm seeing, there's a great deal of collaboration. The public health partnerships. Will County in Indiana is a wonderful example where they are working with the county health, the hospitals, 2 hospitals working with the county. They're using the MAP process, which is the NACCHO process for doing community health needs assessment and planning. I was with a large group of our members, about 100 people, and most of our members have completed doing their first round of assessment. And I said, who worked with the local health department? And every hand in the room went up. So that local health department hospital involvement is happening on the ground. We're real pleased. Something else we're very pleased about seeing is that hospitals are using the public health resources. Certainly, David, the county health rankings has just been a godsend to many hospitals who were just Community health needs assessment, so beyond what we've done before, how do we get started? The county health rankings was a great example. Now, I did work with one of our hospitals in Baton Rouge and was keeping track of what they were doing, and they looked at the county health rankings, though, and they sort of scratched their head because in Baton Rouge in Louisiana, the outcomes, they really do have some poor outcomes. I was reading her final report, and she said, here in Baton Rouge and in our state, we really have a good time, but we suffer from our sins. Because the teenage pregnancy rates, the STD rates, the alcoholism, the smoking, the obesity was just off the charts in all the counties. But it gave them a starting point of where they'd work together. Healthy People 2020, the Community Prevention Guide, organizations are working with. Peggy, we're so grateful for the aims of public health quality. Organizations are using that as a framework very often. What are they finding? No big surprises. Access to health care is probably the #1 issue in many communities across the country. In some of the cities, low birth weight. Mental health has come up, and organizations that don't have a mental health program are realizing that they'd better deal with mental health problems in the community because they are seeing in their emergency rooms and as a compounding factor in trying to treat patients that mental health is a serious problem. Dental health is coming up as a problem, especially for low income, for Medicaid patients. Aging, one of our hospitals decided to do a separate needs assessment just on the aging population, found out, this was in Kansas, a real issue with gambling addictions. A lot of older, very old people going on a regular basis to the casinos and spending a lot of money doing there. Certainly stroke, heart disease, cancer, those are some of the significant needs that our organizations are coming up with. And then finally, organizations are starting to pay attention to some upstream determinants of health. I think Jim's exactly right. A lot of organizations want to go to what's familiar and what's familiar to them. But we do have some organizations. Bon Secours in Baltimore is doing wonderful things with its community members to try to deal with the basic problems of poverty in inner city Baltimore, looking at keeping kids in school, buying up some of the properties that were run down, some liquor stores and porn stores, making them community-owned businesses that are vibrant. In Boston, Children's Hospital is one of my very favorite programs. They discovered they had so many children coming back and back to the hospital with asthma, and they looked at what could we do upstream, and they started giving families who kept repeating themselves in the emergency rooms vacuum cleaners that sort of sucked up those environmental triggers in their homes. So that's the story that hospitals have. I think just some bottom line is that, first of all, hospitals are finding they can no longer only care for that person in the bed, that they must look at how healthy the community is and the community that that patient is being discharged to. And another bottom line is that these requirements are getting the attention of the highest level of leadership in our hospitals. Boards are paying attention, chief executive officers are paying attention because they're accountable now, and that is really making a huge difference. And finally, hospitals are having an excellent experience working with public health, taking advantage of the public health tools, and we hope that we'll see it continue. Thank you.
Thank you, Julie. Please join me in giving this panel a round of applause. We have one final speaker joining by Scott. No, I'm just kidding. Don't worry. I'm pleased to report that we have a break now. Let's abbreviate it just a bit and plan to come back here at 3:45, so in about 5 minutes. Thanks.
Will you ask questions?